Hello, welcome to the second part or part 2 of the lecture on the use of clinical practice guidelines for rational prescribing. In this second part, we'll just take a look actually at some examples of the use of CPGs for rational prescribing, then go to some examples of critical appraisal of practice guidelines, and then end with some conclusions and summaries. So just to show you some examples of how guidelines have actually evolved over years. And that's why whenever we look for practice guidelines, you have to get the most recent and use it. No? And so, given a clinical question that maybe you have a patient who has diabetes, and we all know that persons with diabetes typically actually do not exit because of the diabetes per se, but because of cardiovascular diseases. And so you would like as much as possible to minimize their risk of having cardiovascular events. And when you talk about prevention, you talk about primary and secondary prevention of events. And there are many interventions. It can be use of statins, it can be BP control, it can be blood sugar medications, medications to control the blood sugar. But what if we talk about the drug aspirin, And so, um, in the past, if the question is, should we recommend aspirin for persons with type 2 diabetes, the recommendation previously was actually to use aspirin or any antiplatelet medication if aspirin is contraindicated. And the summary of evidence was because of several randomized controlled trials, that whether you initiate low dose of around 80 to 325 milligrams among persons 40 years old and older, then this should be able to prevent heart disease among persons who are already at high risk for developing it. So let's say older diabetics, so that's why more than 40, established diabetes already, yes, give it routinely. But that's not the recommendation anymore, Over time, what and so this was part of that initial recommendation that if aspirin is contraindicated, that you should use alternatively clopidogrel or ticlopidine, And the evidence, grade of the evidence is actually quite strong, It was evidence grade A or B, So pretty good summary of the evidence. However, recent guidelines, like let's say from the American Diabetes Association, only says to consider using aspirin for primary prevention among those, so it's not anymore 40 years old. It says consider it among those who have had type 1 or type 2 diabetes of if they are more than 50 years of age for most men and more than 60 years of age for most women, or any type 1 or type 2 diabetes with a 10-year risk, which is more than 10-year risk of cardiovascular events of more than 10%. And this includes not only this age group of persons with diabetes, but those who have additional risk factors like family history of CVD, hypertension, smoking, dyslipidemia, or even already with albuminuria in their urinalysis. Furthermore, the American Diabetes Association says that there is no sufficient evidence to recommend aspirin for people who are of younger age, less than 54 men, less than 64 women. However, on the other hand, it says for patients in these age groups, you may still give it, but clinical judgment is required, especially for those with multiple risk factors. So that's for primary prevention. But for secondary prevention, of course, most of the organizations would say to give aspirin as secondary prevention among persons with diabetes who already have a history of cardiovascular disease. So let's say they've had a heart attack, they have a documented coronary artery disease, they've had a bypass, or they have heart failure. yes, aspirin for secondary prevention, and alternatively, clopidogrel for those with aspirin allergy. Now, if on the other hand, you see someone no, who has diabetes and who just had an acute coronary event, the recommendation is actually to combine aspirin and clopidogrel up to 1 year after an acute coronary syndrome. No? So that's how guidelines have evolved. Previously, they were very aggressive in giving aspirin for any person with diabetes more than 40. And then when they look at the evidence again, what they actually found out was that there are safety issues with the use of aspirin, and so they became more careful in the recommendation so that they will only give it when the benefits actually outweigh the risks. And these are for persons who now have a higher risk of CV event because of their age, so more than 54 men, more than 64 women, or for the younger persons if they have multiple risk factors that could predispose them to a cardiovascular event. Now we move on to another example. No? This is for acute uncomplicated cystitis among women. What antibiotics should be given? What are effective? So the question is, the population is acute uncomplicated cystitis. The intervention will be antimicrobial therapy, 7-day typical versus a 3-day course. No? And the outcome that you want is resolution of symptoms or even rendering the urine sterile. So the guideline recommendation actually says that any of the antimicrobials listed below can be used, and the following were listed as 3-day regimen. And the basis for that is actually a meta-analysis, no, that was written by several authors. No, one was written in 1991. This is Dr. Alejandria, no, a Filipino, currently the president of the Philippine Society of Microbiology and Infectious Diseases, and another one, no, a Filipino author. This recommendation is also based no, on a study that was done by Dr. Litan and Dr. Racco, where they have seen consistently high rates of resistance of the most common neuropathogen E. coli to ampicillin and amoxicillin, so that these drugs should be avoided. However, this practice guideline has again evolved no, because of new evidence. And this is the basis for the assignment that have been given. So if you read the study guide, I'm asking you to read only a few pages of the 2013 update of the Philippine Practice Guidelines on Diagnosis and Management of UTI. Use that practice guideline to make a prescription for this particular case of a 27-year-old female at the ER, ambulatory care, consulting for hypogastric pain, difficulty and pain on voiding, and low-grade fever since yesterday morning. She's actually newly married for the last 2 months. She claims nearly daily sexual intercourse, and she's well. She has no other diseases. She's relatively healthy. So you suspect acute uncomplicated cystitis. What would you prescribe? So just write a short prescription and then send it. Now, other examples of how to use practice guidelines and how guidelines very quickly evolve. So let's say in the 2004 clinical practice guideline, there's a question about how to diagnose recurrent UTI. And it says it's diagnosed when a non-pregnant woman with no known urinary tract abnormalities has episodes of acute uncomplicated cystitis occurring more than twice a year, documented by urine culture. No? So it says more than twice a year. In the most recent CPG update, no, it gives more detail. It's diagnosed when a healthy, non-pregnant woman with no known urinary tract abnormality. So there's now a condition of healthy, and then the same as before, no known urinary tract abnormalities. And then it says 3 or more episodes. So that's the criterion, 3 or more episodes of acute uncomplicated cystitis documented by urine culture occurring during a 12-month period, or 2 or more episodes in a 6-month period. So it gives more detail in the definition. Now, how about treatment? No? In the 2004 CPG update, it talks about prophylaxis, no? Where there is continuous prophylaxis defined as daily intake of a low-dose antibiotic. It doesn't say how long to give it. And then also post-coital antibiotic prophylaxis defined as the single intake of antibiotics after sexual intercourse among someone who has recurrent UTI. So how do you prevent recurrences of UTI? So one way is to take prophylaxis, no? Either post-coital prophylaxis or continuous prophylaxis. In the most recent 2015 update, it now tells you how long to give the continuous prophylaxis, and it's a strong recommendation. And the post-coital prophylaxis, it's still the same. And now they have a new category of intermittent prophylaxis. And what drugs to use, no? In the 2014 CPG update, there is this particular list of drugs. So nitrofurantoin, trimethoprim, the quinolones mainly, and cephalosporins. In the 2015 update, no, nitrofurantoin is still there, trimethoprim, sulfamethoxazole is still there, quinolones are still there, the cephalosporins are still there, but now we have fosfomycin already in the recommendation, and even amoxicillin and cefuroxime for intermittent prophylaxis. Okay. One more example for UTI prevention. In the 2004 CPG update, it was silent on the use of cranberry juice. A lot of people were using it, so there was a question about it. In the 2015 update, it does not recommend the use of cranberry products for treatment, but has definite statement on its use for prophylaxis, where it says that cranberry juice and cranberry products can be used among patients wherein antibiotic prophylaxis for recurrent UTI is deemed necessary to avoid emergence of resistance of fecal and urine isolates of E. coli to the different antibiotics. And it even prescribes the dose, no? How much cranberry juice or how many capsules, no? Should be taken, and it's a strong recommendation based on moderate quality of evidence. They even list, for example, some of the cranberry products and even the prices, no, so that the clinician can actually help the patient decide whether they would rather take antibiotics or would they like to use these natural products. So that's very unique in the Philippines. No, we do try to address these issues about herbal products or natural products as part of the recommendations for therapy. Now, I've had the opportunity to work on the clinical practice guideline for the management of this lipidemia, no? In the first one and even in the second one, and now we actually have a 2020 update. But I just want to show you again, no, how the structure of practice guidelines, no. Again, there's a question. So the question was, should we give statins for persons with diabetes? And our recommendation was yes, they are routinely recommended. And this was based again on this table of evidence, which came from GRADE. No? This is the summary table of appraisal. And this is the summary of evidence on the treatment effects of the statin, where we are now given the actual point estimate and the confidence interval so that the reader can actually interpret, no, how strong the evidence would be. And we said this, no, ahead of all the practice guidelines. We're saying that for if you encounter, let's say, a person with diabetes today in the clinic, even if you don't have a baseline lipid profile yet. The fact that this person has diabetes, you are supported by the practice guideline to already prescribe statins. And the basis for that recommendation, aside from all the evidence that we had looked at, is the fact that even among relatively newly diagnosed individuals, within a year after diagnosis, we already found that as many as 10% of them already had ECG changes, 5% had already MI and ischemic changes on their ECG. So by the time that we are diagnosing them to have diabetes, it might already be too late. And so therefore, if you find someone who has diabetes, even without baseline laboratory test, baseline lipid profile, give them statins. Now, moving on, how should practice guidelines then be used by individual physicians? Of course, this should not supplant your own judgment. No, you need to. Of course, the practice guideline will inform practice, but clinicians must also appraise these clinical practice guidelines before adopting and utilizing them. You can imagine that for one health issue, there are many, many practice guidelines. So let's say the example of UTI, there are recommendations from the American Infectious Disease Society, there is from Europe, no? But we want to make our own because we have different antibiogram patterns, no? We have different sensitivity patterns, and that's why for many of the infectious diseases, we do have local practice guidelines. And so we go to the last issue for discussion. How do you appraise practice guidelines? No, and it's the same as in the appraisal actually of other studies like randomized controlled trials, for example. First, one example is from the International Clinical Epidemiology Network. No, this is their appraisal guide. No, I won't really go into much detail, except to say that it's the same. No, you take a look at validity criteria. You take a look at the process of giving their recommendations. You take a look at how applicable it is, no, to our own setting, and you take a look at the equity criterion. And this is important because uh, in a country such as ours, we do want to be able to address problems of equity where there are patients in the country who may not have access to medications. Did your practice guideline actually address this issue of equity? And that was also the reason why we recommended routinely statins for persons with diabetes, because in many parts of the country, they can't even do lipid profile, but we do have in the formulary statins, which can be given to patients at the health centers for primary and secondary prevention. And so equity is an important part of the critical appraisal of a practice guideline. A practice guideline is not that effective if it's not able to address, no, the issues of different kinds of patients who might have problems with access to the intervention, whether by geography or because of their financial limitations. No? So just to address this, is the health problem a priority for all stakeholders, including potentially disadvantaged population? Did the guideline take a look at the possibility of differential effects of treatment in potentially disadvantaged populations? And is the voice or the interest of the potentially disadvantaged actually represented? And that's why I said that most of the time, patient groups are actually part of the discussions. So are they also part of the feedback process, where feasible knowledge transfer strategies also laid out, no, to be able to address barriers in the implementation. So, hindi naabot yung baryo kasi hindi na-disseminate. And that's why some of the practice guidelines are actually in the primary healthcare formulary, so that any doctor in the Philippines is able to read the essentials, no, of important recommendations. And finally, does the impact assessment include evaluation of health gains across potentially disadvantaged populations? So what is the impact of the recommendation? There are actually, as I said, many other ways to appraise practice guidelines, and one of them is the AGREE tool, for example, which has 6 different domains comprising 23 items, and there's a Likert scale. And these 6 domains include the scope and the purpose, stakeholder involvement, and there are many questions on rigor of development. How well made, no, is the practice guideline? The clarity and presentation, applicability, and editorial independence to be able to address conflicts of interest. Now, using all of these questions and taking a Likert scale, you can evaluate a practice guideline, and there's actually a user's guide for this. Now, among all of these different criteria, no, what do you think is actually the most important domain in the appraisal? Here, what they considered to be the most important is actually the rigor of development. And that's why there were so many questions on it, 7 out of the 23, because a badly done practice guideline will not really be able to help our patients. No? So I'll skim through this. No? If you're interested to read through the tool, no, for appraisal, these are just some detail of each of the domains. No? If you are interested to use this tool to appraise practice guidelines, no? And like I said, rigor of development was deemed the most important. This is the process used to gather and synthesize the evidence, the methods to formulate the recommendations, and then to update them. So here, after appraising everything, then an overall assessment is made as to whether you will actually recommend that particular practice guideline. Now, how CPGs can fail? Like I said, they can fail because they're not well disseminated. They can fail because clinicians will refuse to use them because they don't feel that it's valid nor reliable. Or they can fail because they're not relevant to practice. And so it's very important to think about the research or clinical questions before even the practice guideline generation actually begins. Some other difficulties with practice guidelines, no? Many of those who comprise the technical review committee could have conflicts of interest. So can you imagine if you're going to make recommendations regarding drugs, and that person is actually is an employee, of a pharmaceutical company? That automatically makes the practice guideline unreliable, because of that major conflict of interest. Other difficulties, like I said, is the applicability to local setting. We are sometimes very fond of adopting in toto foreign CPGs, without thoroughly analyzing the validity or applicability of the practice guideline, when in fact we do have different epidemiology as compared to our international counterparts. And so many organizations usually adapt rather than adopt in toto. Now, CPGs in public health, in the future, the DOH is actually intent on supporting practice guidelines. This was underway actually before COVID. And the idea is that the Department of Health is going to drive the guideline generation for many different disease concerns as part of the rollout of universal health care. So the CPGs should actually enlighten policy. What will PhilHealth fund? What will be in the formulary? What is in the formulary in terms of drugs should actually be in the practice guidelines. These practice guidelines should also drive quality improvement. We should have less deaths from certain diseases if we are really following the recommendations of the practice guidelines. So just to give you an example, this is a relatively old guideline actually. We came up with a practice guideline for diabetes, type 2 diabetes, and since then, the essentials of this practice guideline have been incorporated in the Philippine National Formulary and is also essentially being followed by PhilHealth. So, like I said, the plan of the national government is already to have a single HTA unit, and this is already ongoing, that is evaluating drugs, devices, and even programs uh, for inclusion, no, into let's say the formulary for drugs, or which devices will the government actually fund. And in the future, no, there is a plan for a national database for our guidelines. And so for Therapeutics 202, you are expected to know how to do critical appraisal of randomized controlled trials, cohorts for studies on harm, meta-analysis, and to some extent even guidelines. You should be able to derive and interpret the results of these studies and apply these results to individual patients. And so in the future, in the prescribing exercise, we're actually going to give you the practice guidelines. But once you become a prescriber in the future, you should be able to get your own guidelines. And like I said at the beginning, you can obtain them for international guidelines from this website or websites of local or international organizations, such as given here. No? So these are just some examples of medical organizations which have online downloadable practice guidelines. Some of these practice guidelines are also published or put together by the Compendium of Philippine Medicine. But the problem here is that they actually print or publish local practice guideline without really much peer review. So that's the only problem with this. It's really just a compilation of practice guidelines. So I think that's already the last slide. Thank you very much for listening, and I hope that if you have any questions that you will put them in the chat and discuss with me any of your questions and concerns. Thank you very much.